Excellent. Thank you everyone for joining us. I didn't press the recording button right up front, but this is our endocrinology update. And if you're not here with us in person, you are required to watch a recording of this webinar by January 12th, 2024. We'll distribute this to you by early next week and then ask you to distribute it to the others in your practice. Now, for new sites, each physician must complete a reflective learning case, and that's just one case that looks at communication and coordination strategies. That's also due January 12th. I'm going to put the link for that in the chat, but we will also send it out to you with this recording and slides after the talk. Next slide.
Sorry.
So value-based reimbursement for next year starts March 1st of 2024. We will ask that the clinical champion attend the spring regional meetings. That would be for PCP practices, nephrology, and endocrinology. Again, if you personally, as the clinical champion, cannot attend that meeting, it would be appropriate to delegate that to another physician in your practice. The clinical champions must also attend the endocrinology clinical champion meeting, and that's going to be virtually in fall 2024. With every practice, we are working at MCT2D towards not just quality measurement and education, but also quality improvement. And so we are going to ask every practice to develop some sort of a process change plan to set a specific aim for quality improvement to increase the prescribing of guideline-directed medications for patients with type 2 diabetes. And we're going to ask you to submit that to us by March 1st, and then work on that process for 6 months, and then share information about what you changed by November. Again, no one is going to be required to meet or hit a specific aim or goal for quality improvement. This is really just practicing setting a goal so that we know where we're going and making changes. And then finally, we're going to ask you to work with your physician organization, with your PO, to choose at least one primary care practice that you might share patients with, and to identify an aspect of care coordination or patient co-management that you could improve, and develop a plan for process improvement. That could be improved referral or handoffs, improved reasons for referral, or something like that. Next slide. And so we are very, very excited to have 5 newly recruited endocrinology sites. Welcome, and we're so happy to have 18 endocrinologists over those sites. And that is it for our administrative updates, and I'll turn it over to you, Dr. Basui.
Well, thank you so much, Dr. Oshman. And again, a pleasure to be here with you today. We decided to provide you with some update on the data and see how we are doing. And with that further ado, just a very quick reminder that the collaborative has actually picked 3 important aims or goals. One being the increased use of continuous glucose monitoring devices in people with type 2 diabetes, given the mounting level of evidence that now has become available with respect not only on improving glucose control, that is now very clear in people with type 2 diabetes initially that were treated with insulin, but emerging evidence is now available for even for people who are not necessarily treated with insulin, and particularly how it can drive changes in behavior, particularly lifestyle modifications. And then, of course, promoting guideline-directed medication prescribing, and use these new classes of medications that have been originally approved to lower glycemia, but now have, again, continued to acquire a mounting level of evidence with respect to strong cardiorenal outcome reduction. And as I'm going to share later with you, quite hot off the press, new data even in people with prediabetes, obesity. And then lastly but not least, promoting low carbohydrate eating patterns that could be incorporated with the other 2 initiatives, again, for better metabolic health and better control of people with type 2 diabetes. So just quick reminder how the attribution of data had been constructed in the collaborative, and I really would like to acknowledge the amazing work that our day-to-day operations leader, Jake and Jackie, as well as Kathleen and Neha, who have been pounding on data to give us an opportunity to understand what impact are we making through our work. So to remind you, patients are attributed to your practice if they have had a diagnosis code for type 2 diabetes and or an A1C of 6.5 or greater, and or have been prescribed a diabetes medication, in other words, a glucose lowering medication, after excluding all codes for a diagnosis consistent with type 1 diabetes. And then, of course, we may refine a little bit this attribution moving forward. We have recently met to increase, the accuracy of the data, but for now, for the cutoff date that is included in these data sets, they were also been required to have been seen at least twice in the past 395 days by an endocrinologist. But we are refining these definitions because it's likely that we might have missed some patients. We also need to be realistic here that we are dealing for the moment with claims data, and there are limitations when one looks at claims data. And for the time being, we only have data on patients with Blue Cross Blue Shield of Michigan, Preferred Provider Organization, BCBSM Medicare Advantage, Blue Care Network, and BCN Medicare Advantage. So obviously, we are missing a lot of patients, but we had to start somewhere, and that's the type of data that you are going to see today. We do not have medication data for patients who have pharmacy carve-out benefits, and that actually occurs when some groups of employers only purchase BCBCM medical coverage and purchase separate pharmacy coverage through a different vendor. So that's another limitation on this data set, particularly when we look at medication use or prescriptions. So you, all of our ongoing and veteran endocrinology practices here are receiving these periodic reports on your practice. And this is just an example. Of course, the Endo 18 is obviously a fake number here. We are just giving you an example how your particular endo practice, it's listed on the left column, and then it put in perspective on the data with the rest of the endocrinology practices on collaborative. And you see here 4 major indications that are important to evaluate disease control, as well as burden of comorbidities, particularly as pertaining to obesity and chronic kidney disease due to diabetes. And then, of course, we also are able to dissect more in depth some of these data sets, particularly as pertaining, for instance, to the stage of diabetic kidney disease based on the eGFR criteria from stage 1 to stage 5. Similarly, albuminuria is also being staged based on normal, micro, or macro. And then, of course, you have information on these major classes of guidelines-directed therapies that are now recommended by majority of associations and organizations here in US, which includes the American Diabetes Association, the American Heart and American College of Cardiology, ACE, and quite few more. So that's the example of practice report. And actually, maybe I should take a quick pause and ask whether anybody had any issues by receiving these reports or reading them, if they are being received as you expect, or any questions regarding this type of reports that you are receiving. So it seems that I'm going to warn Jake that I don't see the chat when I share the screen. So if there is something on the chat, Jake, please let me know because I cannot see it.
Yep, will do. I'll monitor for you.
All right, thanks. All right, so then let's move on then and give you some snapshots of the current statistics of how are we doing in the collaborative. And here are all the endocrinology practices, as you can see here, including more than 16 of the 2,130 patients that are attributed to date to the endocrinologist in the dashboard. We have actually data to approximately 75% of this, or 1,636. Again, to remind you, we have the limitations on the type of coverage that we were able to access. But as you can see here, the mean A1C among the endocrinology practices is 7.15 with a median of 6.8 and a standard deviation of 1.68. So we are continuing to work with each PO to ensure that we have all the data. Jake and all his group are constantly curating data, and we do expect, however, to have data for all patients moving forward.
So we had one question in the chat. Do you want to save them, or would you like them as they come?
I mean, if it's related to this, perhaps best to address them once they come.
Sure, I'm not totally sure I understand the question, so please jump in if I'm not understanding correctly. But the question was, not sure how to see them better, to be higher or lower. Any suggestions on improvement?
So the question is, we don't know how to see the A1C higher and or lower?
No, sorry. So the question is on the report you sent, because I was reviewing them where you put this endocrinology practice versus this step. So
right.
What exactly these number? I mean, there's nothing at the end say, well, you're doing this wrong or that wrong, or you should improve on this or do that more or less. It doesn't tell you if you are better than the average or worse than the average. It's just raw data. For me, I read it, but like I don't know what they mean.
Okay, so maybe I should just go back to that report just to make sure that we are on the same page. This is what you are talking about, right? The endo practice would be endo 18. Here it's an example, right? So this is an example of what we tell you, that how many patients we have the EGFR data, for instance, in this particular practice, and how does that compare with the rest of practices overall. So if we would look at EGFR, which, you know, it's expected to have the EGFR measure at least once a year in people with type 2 diabetes, right? This particular practice is doing actually quite good compared with the others, because it has data in 81% of patients versus overall, which is about 58%, right? The same with body mass index, reportable data. Doesn't mean necessarily that the EGFR was not necessarily ordered. Again, we need to think about the limitations that I have highlighted. And in general, the collaborative is planning to, contact each practices where additional data is needed. But this is in the first step, giving you an overview of how much data collection happens in your practice, if we look at table 1, compared with all the rest as an aggregate. Does this answer the question? It's also,
yes,
these reports are also giving you a snapshot, for instance, on the distribution of patients, let's say, based on chronic kidney disease stages. It doesn't mean necessarily that is like a punitive at all. It is very possible that some practices may have more advanced patients with more advanced complications versus others have less. But this is also to give you a snapshot. How do you compare, like, for instance, how much CKD stage 4 it's in my patient population compared with what's happening in the rest of the endocrinology practices in the collaborative. And obviously this data is very different when we compare endocrinology, for instance, with nephrology practices, because definitely nephrology practices will have a higher percentage of more advanced CKD. But you know, understanding how our practice compare with the rest of the state can also elicit additional questions, whether data is fully complete or there are other issues that we may want to take active action so we prevent perhaps more patients to progress. And the same is true when we look at albumin excretion rates. And then again, the rate of guidelines directed therapies that are active in this particular practice compared with the collaborative as a whole. All right. And as I said, this type of data is also meant to give us food for thoughts and see what else may be done in addition to the steps that are designed as part of the collaborative. So let's move on to other data sets. As I mentioned, here you will see an example that there is a pretty high variation between practices in the number of patients with an A1C. Now, A1C, obviously, it's part of standard of care, and doesn't mean necessarily, as I said, that an A1C may not be in check in all people, but it could be also due to a variability among how these physician organizations are transmitting the data sets to the collaborative. So, for instance, if you review your individual data points reports, and see that the percentage of A1C that the collaborative has received from your practice is, you know, very low, like 30%, and you know very well that that's actually the standard of care is that everybody gets it at least twice a year. That's another way of trying to understand how the data could be transmitted more effectively, and this is happening through the meetings that the coordinating center team has with each PO when they look at all these statistics. And again, we really need your help because this is a process in which we've learned a lot while doing it, right? Like basically learning to fly the plane while we are flying it, and therefore all the you know, constructive feedback that you have to the coordinating center team is very valuable, so we can acquire data that is relevant and as exact as possible. This is actually, as I said, the first statewide quality improvement program, as Dr. Oshman also mentioned. And it is the first that actually has this type of interactive dashboard that allows to compare these various data points over a period of 2 years and will generate, I think, important knowledge about quality improvement and improvement in care for people with type 2 diabetes. And then again, those are all these endo practices where you see the same variability in numbers, with endo 18, for instance, having the largest number here. All right. Any questions regarding this variability in data points?
There's just one question in the chat, and Jake, as long as you can verify I got the right answer, that no matter who orders the test, it should flow into that patient's dashboard.
I was just typing right now. I can give a verbal answer, then still press send. But largely it'll vary. So it's kind of tricky and it'll vary from case to case. But if the primary care practice is also participating in MCTTD, then we would independently receive the lab values from that primary care practice and group it together with the patient at the patient level rather than the provider or practice level. And then that patient would be attributed to both the primary care and a specialty practice, and therefore it would count for both. If the primary care office is not participating in MCTTD, then to the point in the question, if the lab values have been received by the specialist practice and have been brought into the EMR system, then it will depend on that EMR system's interoperability with MyHIN if that value gets sent. So it's going to be kind of a case-by-case things, but those are kind of the two options. And like I say, I'll finish typing that up so that you have that, because I know it's kind of multifaceted.
Thank you so much, Jake. All right, so let's move on. Similarly, here we have been able to have data in which we run statistics on the body mass index across the endocrinology practices. Basically here, pretty much the same number. I think that one of the important distinction is that unlike A1C, BMI, it's not required to be submitted as a HEDIS measure, but it is part of the PPQC package. Therefore, we anticipate that this data will be available also in a much more larger number next year on all of your patients. And Jake will send you the website as relevant, but again, not surprising, a mean of 34, median of 33 in the BMI across practices. And here, as you can see, very similar with the A1C, we have the same very large variability in the number, with some practices having only 4 or 5, whereas others have in the number of hundreds. As you can see, almost exactly the same pattern as with the A1C across these practices. And so let's move on the eGFR. And as you can see here, this is available for less patients than the A1C. Basically approximately maybe 60% at the time being. But if we look at the eGFR as a mean across the practices, we should be quite reassured in a way that majority seem to have a good kidney function, with the mean and median, which are 75 to 79. And here you see again the individual variability across practices. I think that another point that we wanted to make, as we said at the beginning, we don't have data on any Medicare insurances yet or Medicaid. And that type of data, particularly as pertaining to the stages of CKD and overall eGFR mean and median values, could be very biased, because patients who may be much more likely to have more advanced comorbidities are missing from these data sets. And here, along the same pattern. And now we have the urine albumin, which is even less than eGFR. And this is the most recent urine albumin excretion rates that we received in the MCT2D data sets. In general, we try to look at data ever since 2018, but we also concentrated to give you a snapshot at the most recent available value. And therefore, majority of them are between 2021 to 2023. And I know that our data coordinating center is working very hard with each individual PO to make sure that more of this data is transmitted. Because as you can see, we have less than 50% of patients' data for this metric. And along the same lines, here is the variation with some practices, again, transmitting much more than others. Along those lines, here is the distribution on eGFR stages. We were able to do that as well. And as expected, when we looked at the mean and medians, right, we see that we have a pretty low percentage in stage 3, 4, or 5. Again, the same caveat, we are missing important patient populations that could have more advanced disease. So in addition to just looking at the number of guideline-directed therapy, percentage of guideline-directed therapies that are being prescribed per practice as a collaborative endocrinology as a whole and individual, we actually try to dissect a little bit more into these data sets and see how we can look at least in people who should more likely receive these agents, including those who have evidence of diabetic kidney disease. And that's why here we put side by side SGLT2 on the left and GLP-1 on the right, based on the stages of CKD as defined by eGFR criteria. And we don't seem to see, at least with the data that we have, a clear difference. At least with the SGLT2 inhibitor, they are pretty evenly distributed between stage 1 and stage 4. And then surprisingly, actually, there is less in a GLP-1 in stage 4, although majority of them have no restrictions, right, in the presence of impaired eGFR. But it's also possible that other reasons may be, prompting their use in this patient category. It's also possible that an SGLT2 inhibitor would be preferred for benefits reasons, and then potential higher cost with combinations. But then again, as a snapshot, you see that SGLT2 seems to have a pretty even distribution among the 4 stages, and the GLP-1 more in stage 1 and 2. But I would have expected actually to see much more SGLT2 in stage 3 and 4 than in stage 1 and 2. And similarly, here we see the percentage of people that have normal micro or macroalbuminuria, which trends the same with the GFR. And here again, the proportion of SGLT2 and GLP-1 on each of these categories. Again, I would have expected much more SGLT2 inhibitor being prescribed for albumin excretion rates above 300, because in fact, majority of the kidney trials have shown a particular benefit in those who have higher albumin excretion, at least above 200 or 300. But that doesn't seem to be the case, at least with the data that we had access to analyze. And I think I'm just going to go on. So then we also wanted to see how are these patients categorized as far as obesity class, with a majority being class 1, but also equal distribution between class 2 and 3 overall, as you can see in this slide. So 50% class 1 and about 25% the rest. And here is the distribution of the both SGLT2 and GLP-1. And then here we see actually a pretty high proportion of GLP-1 receptor agonists being prescribed, almost, I would say, almost equally among these classes. Clearly their weight benefit, in addition to the cardiovascular benefits, are likely an important reason. And we see actually quite substantial SGLT2 inhibitors being prescribed in these obesity classes. So here we are looking at guidelines-directed therapy specifically, right? Overall, SGLT2 with any other combination of agents, GLP-1 receptor agonist plus any combination, and then SGLT2 or GLP-1, and SGLT2 and GLP-1 together. And that is actually looking at data on patients who had evidence of atherosclerotic cardiovascular disease and heart failure. So in this particular category of patients, like for instance, the most recent ADA and AHA guidelines state SGLT2 inhibitors should be an expected element of care in those patients. And so are GLP-1, which are now first-line therapy, things that have changed in the last couple of years. And even in those categories, as you can see, we still have a lot of work to do, as only about 30%, up to 30% may be on these agents when they have evidence of cardiovascular disease, and therefore this agent should have been first-line therapy.
Dr. Busui, let me interrupt. I think this is for all comers, so all patients in the database that have type 2 diabetes, but not specifically with cardiovascular disease. And I think the point we were making was that because we don't have all of those diagnostic codes in order to differentiate who has a diagnosis of heart failure or echo results, that's what we hope is coming with some of the
thank you, because I thought that when we met with Catherine, that was an idea that we would be able to provide it, but perhaps I didn't realize that that's still not done. Okay, thank you for chiming in, Dr. Oshman. All right, and here are the rest of classes of glucose-lowering agents. And you can see still 30% of people are treated with insulin. And then I think that compared with when we started, there is much less sulfonylurea, much less DPP-4 inhibitors, and very low percentage of TZDs. It is, however, a little bit surprising to us, and we are not so sure about this data regarding metformin, because even if metformin it's no longer the absolute first-line therapy, we still don't believe that only 6% are prescribed metformin. So that's still data that we are researching and validating, but we are sharing it with you in this raw form. And I think that if we look at the trends, and it's always important to see where we started, and as you see, the collaborative started around 2020 in the midst of the pandemic, but we are actually making progress because both these lines have a nice upward trend, and we still have a lot of work to do, but this is reassuring that we are moving in the right direction. So this concludes our data review, and we can continue question at the end, or if you have additional questions regarding these data sets, we can take them now, whatever you prefer.
It'd be nice to go through the education slides since there's not that many of them, and then we'll still have plenty of time for questions.
There's one question in the chat right now, and I don't know that from a data perspective we're able to answer this, but Dr. Oshman and Dr. Busui, Dr. Wyckoff asks, how does Michigan's uptake of SGLT2 and GLP-1 receptor agonists compare to other states or national data?
Okay, so let me put this slide here, right? 26, this is the entire endocrine collaborative, right?
Correct, yeah.
But we do have this data also in the nephrology and primary care practices. So I think that in order to answer that question accurately, Jen, we will need to compile these data sets, because the national data sets that are available, including the Medicare and Optum, are not only referring to endocrinology are much broader. So, but that's an excellent question, and I think that's something that we can definitely do relatively quickly.
Yeah, it's a good question just related to the IQVIA database, which is the one used in many of the publications in the ADA journals. And the data does lag. So in some ways, we're going to have more up-to-date data, but I think over time, we should be able to get those national trends.
And the VA also, the VA was actually, if we look at the VA that was published last year, that was much, much lower. But I think that they are reviewing their data sets as well, because at the VA, these medications are completely covered. And still last year, it was only about 11% nationwide. But that's a great question. All right, so what we also wanted to share with you, and I'm sure that many of you are already aware, but since this is so hot off the press and it was just released a couple of weeks ago, we wanted to share with you this first cardiovascular outcome trial done in obesity without diabetes, one of the largest trial with an GLP-1 receptor agonist, semaglutide. And I'm sorry that this table is relatively small, but it included more than 70,000 people with obesity, defined as a BMI of 27 or greater, no history of diabetes, and actually exclusion of diabetes was an exclusion at baseline, but they had to be at least 45 years and have other pre-existing cardiovascular disease. And if we look here at this table, I hope you can see it. The age, it's about 61. The proportion of male was actually higher. They were predominantly men because they had to have some evidence of cardiovascular disease, so 72%. About 83% were white, with about 8% Asians and 10% Hispanic. So there was some, racial diversity, but this was a global trial. It was majority of patients were in US, about, I would say, 40%, but the rest of the world participated in this trial as well. And A1C at baseline was about 5.7. And I said these were pre-diabetes, but no diabetes. And the distribution of cardiovascular disease at baseline was either prior MI, majority qualify based on having had a prior MI, about 20% a stroke. And then also peripheral arterial disease was an accepted evidence of CVD. The eGFR was pretty good, and as you can see here, the lipids variable were relatively well controlled at baseline, as was the systolic and diastolic blood pressure. So this was a typical randomized controlled trial. Patients were randomized to either semaglutide that was titrated to 2.4 milligrams a week, and it was encouraged to be maintained at that dose. And here is the primary outcome, which was time to first event analysis, and the primary cardiovascular composite outcome was the traditional non-fatal MI, non-fatal stroke, and cardiovascular death. As you can see here, an impressive 20% reduction in the risk of the primary composite endpoint with semaglutide compared with placebo. This is actually a higher risk reduction that was observed, as you may remember, with GLP-1 receptor agonist in diabetes, where we were seeing about a 16 to 17%, 17% reduction in risk. The death from cardiovascular causes was trending, but did not reach significance. But the other very important and hot, findings was that it's the first trial that actually shows a clear benefit on heart failure with a GLP-1 receptor agonist. So you can see here an 18% reduction in the risk of heart failure. That obviously had been received with a lot of enthusiasm at the American Heart Association meeting 2 weeks ago in what's presented. And as you can see here, also a significant reduction in death from any cause. And then, there are multiple other binary and continuous secondary endpoints here. It shows how the change in A1C happened in semaglutide versus placebo at week 52 and 104, and then the change in body weight is accepted about 10% reduction in body weight, important reduction in waist, blood pressure. The heart rate was increased as expected by about 3. And that's again a consistent effect with GLP-1 receptor agonist. And then there were also a variety of patient-reported outcome, including quality of life. The trial also looked at potential mechanistic reasons, and there are biomarker ancillary studies that are now being ongoing, but as you can see here, there was a clear reduction in CRP levels, so the overall chronic inflammation, which is obviously hand in hand with weight loss and insulin sensitivity likely. But I know that we have obtained, biosamples, and several additional biomarkers are planned to be tested. In addition, cognitive measures as well are planned to be addressed, particularly with such a large sample size. The AE and SAEs were clearly as expected. I did not put a slide here, but there was no signal whatsoever for pancreatitis or pancreatic cancer. As expected, the majority of AEs were GI related. And in fact, the most important reason of drug discontinuation were GI related. But again, if you are interested, I can delve into this data, because at the meeting, we were able to look at rate of discontinuation in GLP-1 in the active drug here in US, which was by far the highest. 28% of drug discontinuation happened in US, whereas the rest of the world were in the margin of 3 to 4% of patients that were discontinuing the drug due to GI side effects. Again, very different, I think, expectations and reaction to the nausea and the vomiting or diarrhea that some patients may experience with semaglutide. We wanted to provide you this because this was hot off the press, and it was really very exciting, moving actually the field. In fact, our cardiology colleagues at the AHA were saying, well, obesity now it's a cardiology complication, so we should take over treating obesity as well. So that was, of course, an interesting comment that they made. So where shall we move further? And definitely all this evidence, it's being incorporated as we speak in guidelines, and the American Diabetes Association standards of care are going to be released in a couple of weeks in December. But that's from last year, and clearly all this evidence makes available to us multiple new tools on how to screen and how to treat these patients, how to identify the phenotypes of people who are more likely to benefit of a given intervention versus a different other intervention, and how to, guide team approach and collaborations across specialties, because our goal is obviously to try to give the best care that we can to all our patients. And it's also the goal of the collaborative, because guidelines are constantly updated, and they are there as a guide in our day-to-day clinical care. But we know very well, and we are learning together here, that from these guidelines to the actual clinical care implementation, it's really a very, very long process and requires a lot of work and understanding all this data and how evidence from a clinical trial that gets translated into a guidelines applies to the daily patients that we see in our clinic. It's something that the collaborative is here to be able to help and do. You know, as a food for thoughts, we want to get your feedback, how we can do this better, how we can better integrate all this data, all this evidence, and make the delivery of care easier and accessible to all. With that, I think we wanted to leave a lot of time for questions, and here we are. Thank you.
We have about 10 minutes left for questions. Happy to answer the question in the chat, and then please unmute if you have them. So Dr. Bisui, the question about the SELECT trial, do you know if they're planning to look at sleep apnea?
Oh, no, we did. I can tell you, I was an investigator in the trial, and a sleep apnea was not collected. But it's a great question. I see now, I start to see the chat. Let's see. Will there be more patients? Guidance on the... Oh, will there be more guidance on the process improvement plan due in March? I think that I would let Dr. Oshman and Jake answer that question.
Yeah, so if you do have specific questions, Dr. Lager, please feel free to reach out. We do have the PO monthly calls, as well as our PO monthly digests that we send out, which will contain additional information and continue to have reminders on those as well. So more information and repeating of the same information will be available from those mediums. But like I say, if you do have specific questions, please do reach out so that we can be proactive and get you any responses and answers that you need.
I think the other thing that I would add is that we've started this with the primary care practices at the PO level, so that all primary care practices in an individual PO are picking an individual improvement goal. And so by the time March comes around, I think we're going to have a lot more experience from that to share with you on what they found useful and what was challenging.
Yep.
Oh, there is another question. How is the data being collected from the practices now?
Yep, I can answer that. So the way that the data flow for this works is POs submit what's called PPQC, or Physician Payer Quality Collaborative data, to the Michigan Health Information Network, as well as claims data, which is submitted from Blue Cross Blue Shield and VCN to MyHIN. And those data sources are then transferred to another group that is housed at the University of Michigan called the Michigan Data Collaborative, or MDC. MDC is the data warehousing group, and they are our data vendor for MCT2D. They take the data that they receive from MyHIN and build it into our database and our dashboards. And so we're solely reliant on this flow of data. Obviously, patients with type 2 diabetes are very prevalent, so we can't do manual data abstraction at the sites like the other legacy CQIs have done. Therefore, we have to have this automated data transfer, and some of the difficulties that we've had comes from that. Dr. Oshman's just pulled up a screen here that shows the flow of data, and so you can see it's a complicated process. So the coordinating center, that's us, have identified a population of interest, that is patients with type 2 diabetes. Namely, there's 3 criteria that brings a patient into it: either a diagnosis of type 2, or being on a diabetes medication, or having an elevated A1C over 6.5 without a diagnosis of type 1. And then MDC works with MyHIN, who receives that data, that PPQC data, already, typically through the Blue Cross Blue Shield PO vendor initiative and through HEDIS measures. And then receives that EMR data back, and then are able to build out these dashboards.
A statement, not a question, but one we can address. SGLT2 inhibitors are expensive. Dr. Basui, anything to add?
Well, I know that very soon one will become generic, DAPA. I think it's scheduled for 2025 or last trimester of 2024. But you are right, they are expensive, as are the GLP-1 receptor agonists, and most recently we're also dealing with the shortages, right? Particularly with semaglutide, and likely things will happen due to a variety of reasons. But all this new evidence that it's accumulated, particularly on heart outcome reduction, will drive eventually lower costs, because the more of these payers are able to participate in, coverage plans, could help with pricing. In addition, as I'm sure you are very aware, the American Diabetes Association has been at the forefront of fighting for equal access to medications, to insulin. We did have a major victory this year with the insulin, including with Eli Lilly initially, capping the insulin at $35. That was then, endorsed by Sanofi and in a certain way by Novo as well. And we are also lobbying, the Congress to act on the Insulin Act, which is sitting there in the House. Hopefully things can move forward there. And we've been very active. We have actually been able to get the CGM coverage through Medicare in type 2 diabetes, again, lobbying very, very hard this entire year. And we'll continue to do so. And we are continue to actually lobby for this life-saving medications, because and in fact, I want to share that here at Michigan, we are doing this very nice quality improvement on how to screen people with heart failure and diagnose them in much earlier phases, because once we see and give the the proof of how much heart failure is there, and then these medications can prevent hospitalization for heart failure, which are very expensive. That's another argument that can be used to payers. But it's a lot of work to do, and we are working basically continuously on multiple fronts to increase the access to either technologies or medications. And we should all, actually, you have a voice as well. ADA sends all these messages, to send messages to your representatives, and don't ignore those messages. I know that Endocrine Society is doing something similar. So we need to fight together on all fronts.
Dr. Basui, one of our participants, thank you so much for noting that steglatril is now generically available. There's another medication called bexigliflozin that's not available in pharmacies and only by this Cost Plus pharmacy, that's Mark Cuban's pharmacy. I think the more important policy change is that given the Medicare Inflation Reduction Act, Medicare is going to start to be able to negotiate drug prices, and both Jardiance and Farxiga are negotiable beginning in 2026, and it has to do with a certain amount of time after patent. So I think, Dr. Basui, the question I have is,
but actually what I want to say is that those are part of the 10. Also, ADA was able to include, as you know, 5 diabetes medications in the Medicare negotiation with pharma and with big pharma. So that's another important legislation that needs to continue and not be blocked, because SGLT2 and GLP-1 are part of that.
And so then the last thing I would add is just making sure you go to the website if you haven't been there recently. We have redesigned the website so it should be easier to find things. And among those, we continuously update our tool for insurance coverage, which most people, I think, it's not perfect, but find very helpful to understand and save some time. We have a few minutes left. Any other last questions? And we'll wrap up.
Only with steglatro, we don't have, unfortunately, the outcome evidence like we have with the others. Yeah, great. Well, pleasure actually being here tonight and meeting you. And thank you so much for your questions. And we welcome more thoughts moving forward. And we really value partnering with you. Thank you so much.
Thanks so much, everyone, for attending, and thanks, Dr. Papasou, for a fantastic meeting. Have a good evening, everyone.
Bye.
Dr. Ashman, I'm going to go ahead and stop the recording.